palpation, we go here. So again, starting at the palpating at the lateral patellar margin, patellar tendon, tibial tuberosity, lateral femoral condyle, head of the fibula, lateral joint line, the anterior joint line going laterally. Okay. So if there's any point tenderness there, especially along the joint line, then you should suspect a problem with the meniscus, and you do the special test later. Then after that one, we then proceed to the next part of the exam, which is movement. So we do both active and passive movement of the knee, as well as testing for the hip, because sometimes, as you know, knee pain is a referred pain. So first, passive movement. So here it's quite, the gap is only 4 finger breadths, which is more than expected. If I actually press further, she can actually touch her heel to her thigh, which could mean that she has some laxity there. So flexion and extension is normal there. Now I'd ask you to bend your knee. Okay. Yeah, bend it like that. Okay, straighten. Other side. Okay, it's good. All right. And testing for hip internal rotation, external rotation, as well as some hip abduction and adduction. There's no clunk or pain there, so that's fine as well. Also, by flexing this, you can actually, I'm just palpating whether there is some crepitus here, and by moving the patella sideways, there seems to be no patellar apprehension there. After the look, feel, and the move, then we proceed to the special test. So first we test the integrity of the ligaments. So first, testing the anterior cruciate ligament, we do the anterior drawer test. So by this, we let the patient flex the knee 90 degrees. We stable the foot there, and by relaxing the hamstrings, we grab the tibia and pull it forwards. What we're looking is for end point there, or increased laxity anteriorly, and that was entirely normal there. Alternatively, people also do the Lachman test, which is basically flexing the knee 20 to 30 degrees. In the video of Dr. Meyer, he suggests, because I'm a bit lateral, to rotate the hip a bit so that the knee is facing you, and then with one hand here and one hand here, you pull it forward. Okay, there's no increased laxity. In the GP conference, there was one suggestion of the other examiner to actually put your knee, okay, position, and then you can actually do a similar one, a Lachman test as well. Okay, that's normal as well. So obviously I'll be doing that to the other side as well. Next is a test of the medial and lateral collateral ligaments. So I normally test this by patient, just lying down, and the other one by grabbing it, lifting off the bed. So by applying valgus force here, I'm testing the integrity of the medial collateral ligament. So obviously, they say 5 to 10 degrees or a little few millimeters movement is normal. And testing now the lateral collateral ligament, applying varus force, that seems normal as well. So how about we grab this one here, okay, and doing the same. A little bit of movement on the lateral side is normal as well. So now we've done the anterior, posterior cruciate, then the ligaments. We then proceed to the testing of the meniscus. So checking for any injury or damage to the meniscus. First of all, the history is very important. So if the patient points pain around the joint line, and if you have tenderness, then it's then you'd suspect, and you supplement that with the McMurray test. So basically, the McMurray test is fully flexing the knee, holding the your finger here in the joint line. Then by externally and internally rotating the leg, you are locking the meniscus here, and if there's any pain in the medial lateral side, then you suspect that one. So we do that now. Any pain there? No, so that's normal. So you can see the good movement there. Then what you do is externally rotate the leg and then extend it. Okay. So normally if there's when you do that, the McMurray test, and there's a painful clunk on the medial side in that maneuver, or a pain in the lateral side with internally rotating and extending the knee, then you suspect a damage of the meniscus. Lastly, we test the Q angle of the patella. So anterior superior iliac spine, straight line, and then the angle it forms with the tuberosity. So in females it's 10 to 12 degrees, so that's normal for her. Checking the movement of the patella. So if you check the diameter of the patella, movement to 1/3 or 2/3 is normal. So she can move her patella there to like about 25%, so that's normal. And as I was doing earlier, checking for the apprehension test for patients with recurrent patellar dislocations. So this is a bit the essential points of the knee exam. So I conclude my examination at this point. Thank you very much.